Hello, my name is Dr. Derek Lee. It's my pleasure to introduce Dr. Stuart Weinstein, who's Ignacio V. Ponzetti Chair and Professor of Orthopedic Surgery, Professor of Pediatrics at the University of Iowa Hospitals and Clinics in Iowa City, Iowa. Welcome, Dr. Weinstein.
Nice to be here.
Today, I'd like to really discuss quite a bit more, actually, on the natural history of scoliosis. And who better to talk to as opposed to yourself? You've done quite a number of studies on the Iowa University protocols in terms of tracking scoliosis, actually over 50 plus years. Is that correct?
Yes, it is.
Can you tell us a little bit of a history about your involvement in that at the beginning? Because I know the retrospective reviews began in 1976. You take us back to that time and what the purpose of the study was and your involvement?
Sure. Well, I began as a faculty member here in 1976, and what was wonderful for me was a treasure trove of patient records. The founder of our department, Arthur Steindler, who was quite a well-known orthopedic surgeon in his day, came to Iowa City in 1913 and was chairman of the department until 1948, and he was an extremely bright man, trained in Europe, and was an expert in lots of things. But one of the things he was very interested in was biomechanics and scoliosis. But he had a large patient population of scoliosis patients, idiopathic scoliosis patients, who came here to see him for his expertise of the day, which did not include the treatments that we know of today, bracing, and certainly no surgery at that time, except for maybe in situ fusions for very severe cases. But the bottom line is he had a large cadre of patients who were extremely loyal to him. And in 1976, I began tracing this large group of what we would say are untreated patients. And over a 2-year period, I was able to find well over 200 of them and asked them to come back to Iowa City for a clinical examination and x-rays. And this started my relationship with these patients. And then as part of that visit, I asked them, would it be okay if I contacted them approximately every 10 years to see how they're doing? And subsequent to that, I continued to follow that cadre of patients and then continued looking for the ones I couldn't find. And eventually I found another 22 patients. So basically I had information on over 200 patients. I had information on all of these patients for their lifetime. Basically at the last follow-up, their average age would be senior citizens age, 65. And we had lifetime natural history of how scoliosis affected their life. So that's where the group came from, and that's how we established this relationship to do the research follow-up.
Quite a long-term study. How did you keep your enthusiasm over the last 50 years? That's amazing.
Well, I think if you're a scientist and you have this amazing opportunity, there's never a shortage of enthusiasm for finishing this project out. Obviously, I was doing other research at the same time because this is only every 10 years. But the fact of the matter is being curious about a disease and knowing the natural history is really important, because if the natural history turns out to be totally benign, there's no reason to treat it. And there's some conditions in children's orthopedics which seem significant when they're diagnosed, but they totally evolve to normal children. So there's no need to treat it. You can reassure the parents. But idiopathic scoliosis, when I was training, had a very bad reputation of being a disease that would cause you paralysis. If you were a woman, you would never be able to marry. You would have difficulty bearing children. If you did get pregnant, your curve could get worse. You might be disabled by it, and so on. So the natural history that I had read about in training was disastrous. And then I started looking into those studies and realized they were not idiopathic patients only, but those studies included patients who had, for example, neurologic disorders, had congenital scoliosis, had to scoliosis secondary to various diseases. So it was not the natural history of idiopathic scoliosis. So for me, it was really important, if I'm going to offer treatment to a child, to know exactly, what the natural history would be for that child.
Yes, I was reviewing, there were a couple studies around 1968 that I think you're referring to that kind of predicted the natural history of scoliosis as being very horrific, really, in terms of the outcomes. And they, like you said, they did mix their population database with different forms of scoliosis at that time. With respect to the 200 roughly 20 patients that you started off with in 1976, how many are still with us today, and how many still participate, I guess?
In actuality, we felt that after we had taken them to senior citizen age and that they had had normal lifespans, it didn't increase their mortality. And most of these folks had had normal lives as far as marriage rates, jobs, they weren't disabled. We felt that we had outlined the natural history well enough that we didn't need to trouble them any further, and that we had enough information to put out there for folks to hang their hat on.
Absolutely. I kind of find it interesting how it, through medical history, you'll have almost like urban myths. You have like a study that's being quoted 20 years ago or 40 years ago, and that becomes the dogma as time goes on as well. For instance, with severe curves, it's going to crush your organs, et cetera, et cetera. Were you surprised with the results that you were able to gather over the 50 years of the study?
A little bit, because obviously I had trained under the literature that I had quoted already, which wasn't very good. And in seeing patients, I didn't think that it was as bad as projected in these studies. So I was, let's say, happy that the outcome was much better than I had read about. I wouldn't say I was surprised, because I was obviously, that's what the main focus of my practice is. So I'm seeing these folks every single day and knew that their quality of life was good and that they were having normal lives. So I was just glad the study reinforced my day-to-day perception of how patients with scoliosis were doing. But to emphasize what you just mentioned, these myths still persist even today, even after our study, that we see patients all the time. We're told they're going to be disabled, or they become paralyzed, or they shouldn't participate in sports, et cetera, et cetera. So what I think is important to realize in medicine is that there's it's very difficult to overcome myths and personal perceptions that people may have about conditions which are not necessarily grounded in anything.
Well said, well said. And that's basically the major reason I wanted to talk to you after doing some research on you and reading your studies. I was wondering if we could kind of dive down a little bit into a little bit of the details of your study, and maybe you can expand a little bit.
Sure.
Sorry, go ahead.
No, go ahead. You go ahead.
Okay. I guess the first one I'd like to touch on is curve progression, in terms of even today, the data is sometimes a little bit unclear in terms of I guess in general, it seems that curve progression these days, it seems to be linked to growth spurts, especially for AIS with adolescent idiopathic scoliosis. And if, depending on your age, your BMI, where you are in terms of curve maturity and hitting growth spurt, that factors in the curve progression. But once you mature spine, there seems to be not a lot of data in terms of what happens with curves over time, which is why I wanted to talk to you as well. So before, you had research indicating that it might be a 1 degree curve progression every year for curves over 50 degrees. Can you expand on what your study found?
Sure. Well, excuse me, with respect to curve progression, you can take a look at the natural history part first, then also our bracing study added a lot to the overall assessment of a child and risks of progression. But if you take the natural history group, we didn't have all the sophisticated growth information on that group of patients because nobody was actually looking for it. So we just have basically their curve x-ray over periods of time. And what we could generally say is that if you look at the aggregate of all these 220 some odd patients, you can see that the aggregate, the whole group, their curves progress slowly over time. But then when you drill down on it, what I feel very comfortable in telling a parent today is if your curve is under 30 degrees at skeletal maturity, it'll probably never get worse. I feel comfortable in advising a patient today about that based on the natural history study. When the curve is definitely over 50 degrees, particularly if it's a thoracic curve, there's a high likelihood that it will slowly progress over time. Now, it's not necessarily a degree per year. That's kind of an average. Some patients with significant curves may progress, let's say 10 degrees in 1 year and maybe 1 degree the next year. It's no way to predict that. So we just know that if your curve is over 50 degrees, there's a high likelihood that it will slowly progress over time. But those are patients, if you're a young patient over 50 degrees, today we would treat them very different. They wouldn't just be observed. So when you're talking about a mature patient, I would say comfortably, if your curve is under 30 degrees, it'll stay there. If it's over 50, it most likely will progress. And then you have this 30 to 50 degree range where I would say, it's a good idea to keep an eye on it. Maybe see somebody every decade. Just get an x-ray, see how it's doing. How are you feeling? Are you taking care of yourself? Do everything you can do for wellness sake, as far as core conditioning, physical fitness, to keep yourself healthy, and then keep an eye on it. You don't need to be fearful of it, but they're not exact predictors. So that's mature patients. When you come to immature patients, who are the kids who are coming to our offices for active treatment in the years, let's say 10 to 15, we know so much more about maturity factors than we did 40 years or 50 years ago that it helps us make decisions. And we know there are many maturity markers, such as the Risser sign, which is a classic ossification of the iliac apophysis. There's digital skeletal age. There's looking at the growth centers at the elbow, the growth centers at the thumb, the growth centers at the wrist. There are many of them that are better predictors of where the child is on their adolescent growth spurt, because we know that growth is your enemy. If you still have significant growth potential, then we can know that that's a negative factor in curve progression. So in 2022, we have so much more information we can bring to bear to help a family decide about, is treatment necessary? What's the future? But I guess for the listeners, immaturity is a negative factor. It's a higher risk of your curve getting worse. Once you're mature, again, to reemphasize, once you've finished growing, if your curve's under 30 degrees, I think you can feel quite comfortable. Over 50, I'd be a little concerned, and it bears watching. And in between there is more of a gray zone, which if it were my family, I would have my child or my partner or significant other follow up every 7 to 10 years just to keep an eye on it.
That's excellent points. We can dive down into each of those with the immature and the mature spines, if you don't mind. So with respect to the natural history, many surgeons use 50 as the kind of the cutoff in terms of for considering surgery. And many surgeons, as you know, would recommend some sort of surgery at that point. And that conflicts a bit with the natural history of scoliosis in terms of for a 50-degree curve, there's so many variables involved that as time goes on, osteoporosis, the nature of the size of the curve, the location of the curve, etc. How do you know when it's a necessary time to have surgery for mature spines?
So if you're a mature patient, so everything really depends on your maturity. And again, immature patients, the decisions are very different. But a mature patient, it's always a patient decision. It's not a physician decision. It's a patient's decision, and the physician should be the navigator for the patient to help them make an informed choice. So not every adult who has a 50-degree curve is going to get worse. Some may stay the same. There's absolutely zero reason that a patient needs to rush in to have surgery. They need to think about these things. If it's let's say it's a thoracic curve where pulmonary function can be affected. Well, you can get an objective parameter. You can get pulmonary function tests. Are your pulmonary function, is it normal? And if it's normal and you have a 50-degree curve, to me, and it doesn't bother you from a psychosocial standpoint, you're not unhappy with your feeling about yourself in society, there's absolutely no reason to have surgery, in my opinion. And I would check it again in 5 or 6 years, see how it's doing, see how you're doing. So I think it's a misconception to think that someone has to have surgery. These are patient choices that should be made after they're totally informed about their own personal situation, as well as what does the literature show about someone who might be similar to you. But patients are individual, and I strongly feel that these are patient decisions, and I, as the surgeon, even though I might be doing the surgery at some time, I'm their navigator until they decide to make that plunge, that they feel it's the right decision for them.
Very good. Because it seems that many patients with scoliosis, with severe curves, let's say 50-degree curves, and they're mature, are worried about progression. And they feel that if they have surgery at a later date, they're older, it's a tougher recovery, versus worried that it might progress, because it's human nature to always focus on the negative, right? What if I'm the one where it's going to progress to 60, 65 degrees, as opposed to what if I'm the one who's not going to progress, right? So it's a difficult choice, but I appreciate what you're saying in terms of just keep monitoring it, see what your situation is. If you happen to be in severe pain, if there's significant degeneration, and maybe those variables will add to the decision making.
I think the points you make are quite good. That number one, the indications for an adult, someone who is mature, the accepted indications are a curve that's getting worse. Okay, it is progressing. Number two, it's causing you pain or discomfort that you can be certain that is caused by the curve, not some other source of pain. And the third, much softer reason, but a valid reason, is you're just unhappy about it. You don't want to worry about it. You are not happy with your appearance. You're worried about the fact that the risks of surgery increase as you age. So the surgical complication rates, let's say in a 25-year-old, are quite low, let's say 1%, 1.5%. Whereas you're for 40 and you're having the same surgery, the complication rate or morbidity could be slightly higher. And if you're 65 years old, it's even higher. So those are valid reasons that patients need to articulate to their caregiver. And I hope folks don't take the impression that I'm saying you shouldn't have surgery. I think it's just an informed choice that you make surgery, not that it's routine, automatic. Your curve is 50 degrees, you have to have surgery. You don't ever have to have surgery. The patients in the natural history group never had surgery and they had normal lives. But I will mention one thing about the natural history study, which resonated with me, is that most patients wish they had choices when they were young. They had no choice. There was no treatment. So they had to, take natural history as their choice. But almost every one of them said, I wish I had choices when I was younger. And the second thing about it is that many people were, not very pleased with their appearance. Many of them voiced the fact they felt, that they wouldn't wear a swimming suit. They didn't want to go to the beach. They would wear clothing that would cover their scoliosis because it is, quote, a deformity, and they felt that way. So I think that's a real factor that needs to be discussed with particularly adult patients. I think children often don't bare their souls in front of their parents or to the doctor about how they feel about themselves. So that's a little difficult factor to discuss in an immature patient population. But mature patients, you can always and should always have that conversation.
Absolutely. Well said. It also seems that, the natural history versus surgery. And surgery also has complication rates. And it seems that if you have long fusions into the lumbar spine, you start dealing with issues, complications like adjacent segment degeneration, other issues in terms of not, even with Harrington rods before, not managing the sagittal curves properly. Do you have any insight into what you're seeing? Well, in surgery has been improving in terms of posterior spinal fusion with medical screw technology, trying to manage sagittal curves a little bit better. From what's your insight or your perspective on surgery these days, especially going into the lumbar spine versus the natural history of scoliosis?
Yeah, I think that having done surgery now for 47 years and starting in the Harrington rod era, what you can say about surgery is that the technology is so far superior today than it was, even 25 years ago. The use of pedicle screws, the ability to save segments. I think as a surgeon, you want to fuse as little of the spine as possible. Selective thoracic fusions, stopping as short of the lumbar in the lumbar spine, as high in the lumbar spine as you can possibly do to preserve motion segments. I think these are all things that now are possible that weren't possible even, let's say, 25 years ago. So the technology about curve correction and what we know about, again, paying attention to the sagittal plane, which when I started out, we only looked at AP x-rays. We never even looked at the lateral x-ray, for example, which, is heretical today, but that was the truth, 47 years ago. And so the ability to do better corrections, shorter segment fusions in a safer surgical environment. We have spinal cord monitoring. We have drugs we can use to prevent blood or to lessen blood loss. We have anesthesia colleagues who are so much better at doing spinal deformity surgery in children. So technology has gotten better. The environment in which we do surgery has gotten better. And I think hopefully long-term follow-ups of the things we're doing today will stand the test of time. I do think that they will hopefully improve natural history. They do definitely, as far as the psychosocial aspects or the body contour aspect of having the spinal deformity. That's definitely much better. And hopefully the patients will function better in modern society, and that these fusions will be durable, last a lifetime. And I think we know that, I think that even though the technology of 25, 30 years ago is not the same as today, I think we know that studies, for example, ending the fusion in the upper lumbar spine have stood the test of time. Patients are doing well. And I think you could feel comfortable telling a mother and father and the child that, you're going to have a normal life as long as you take care of yourself. But you cannot prevent the aging process, so that, we're all going to get older at some point in time. Your spine is going to get older. And whether you have surgery or not, degenerative changes can occur. I mean, any one of your adult spine colleagues can tell you, they see patients who don't have scoliosis and they have plenty of degenerative disease that occurs with the aging process. So I'd like to think that we're helping people, but you cannot prevent aging. So adjacent segment disease and other problems may develop later in life, and those are not predictable.
Excellent. Excellent points. If we can only stay young. Now, if we can dial it back a little bit, we spoke a little bit about mature spines, natural history, and of course you were one of the leaders with respect to the BrAIST study, which is revolutionary as well. What are your opinions on surgery for adolescents? Is there a cutoff? Is there a natural history? What's your perspective on surgery for adolescents?
Surgery for adolescents?
Yes.
Yeah.
Yes.
I think the standard indication for surgery in a growing child, someone who still has growth potential, I think everyone would agree that a curve over 50 degrees in a skeletally immature patient has an extremely high likelihood of continued progression. So I think that's a pretty standard indication for surgery. Now, some people may say 40 degrees is a standard indication, but I would say the measurement error of x-rays is 5 to 7 degrees, whether you do them digitally or manually. So I think that, once again, there's also no hurry. There's not like this is an emergency surgery. These are all elective surgeries. You can afford to wait. So in my practice, if the curve is over 40 degrees and the child is skeletally immature, I start talking to the family and the patient about the potential. This may continue to progress, and we may need to talk about what do we want to do? Do we want to do surgery at that point in time? But I don't, it's an education process. It's a discussion. It's not, you have to drop your family plans, drop out of school. We need to do surgery tomorrow. This is not emergency surgery. This is still elective surgery, even in a growing child who will need surgery. It doesn't matter if it's done in 2 weeks, 2 months, or even 18 months, probably. You still can get a very good result with modern surgical techniques. It's a matter, again, of a patient and family being informed about risks versus benefits and understanding what they're getting into. There's nobody that ever wants to have surgery as far as a child or their parents. But I think they need to be informed and be able to ask questions and have resources to look at and think about before they make a decision. But I think the standard indication is a skeletally immature patient with a curve over 50 degrees.
Mm-hmm. Now, in your practice, especially with the results from the BrAIST study, I assume you do bracing, et cetera, et cetera. Is there a particular, what are your parameters for bracing in terms? Is it 20 degrees, is it 25 degrees? If there's a family history of scoliosis, is it lower? You start with nighttime bracing, full-time bracing. If you can talk about that, that would be terrific.
Sure. So I'll tell you that before the BrAIST study, I was a bit skeptical about whether braces work or not. I can understand how braces work on your teeth because it's fixed to the skeleton.
Mm-hmm.
I can understand how anything fixed to the skeleton can alter the skeleton, but I was unsure about pushing externally by a device could work. So I was a bit skeptical. And when I reviewed my own results of bracing, starting with the Milwaukee brace, which was the first brace used, they were not so good. And then switching to underarm braces, what's often called thoracic lumbar sacral orthosis, TLSOs, we still had a fair high failure rate. So I started saying, well, is this my orthotic shop and is this me or is it everywhere? So Lori Dolan and I did a literature search and literature review, and we thought, it's pretty hard to show that braces do work. And at the same time, the U.S. Preventative Task Force on Screening came out with a recommendation against school screening for scoliosis. Their review of the literature, like our review, showed the same thing. They said you can't say that braces work, so therefore If you don't have effective treatment, why would you be looking for something? There's no way to treat it. So what's the point? So these were all impetus to do the BrAIST study. And as you know, the BrAIST study was a high level study, which supported by the government, the National Institute of Health, the Canadian equivalent of the National Institute of Health, the CIHR, the Shriners hospitals. And basically, it showed that braces do work. It's level 1 evidence. And I would say as an orthopedic surgeon, there's very little that we do that's that high level evidence, but bracing unequivocally works. And it unequivocally works in 90% of patients if you wear it at the prescribed time, which as an aggregate is generally over 14 hours a day. So the take home from the BrAIST study is that braces do work to prevent the need for surgery. Number 2 is that it does matter how much you wear your brace. So for me, the indication for bracing is a curve over 20 degrees, more approaching 25, under 40, because it doesn't work over 40, in a skeletally immature patient. And the definition of skeletal immaturity keeps changing. In the old days, for a young lady, it was having your periods less than a year and having a Risser sign of less than 2. But I think today we have better assessments, as we talked about earlier, of maturity. And so we look at the triradiate cartilage, which is a growth center in the hip. We use digital skeletal age, which has been shown to correlate highly with the peak growth velocity. And so an immature patient with a curve over 20, 25 degrees, under 40 degrees is the ideal brace candidate. And the time you were, then I don't do nighttime bracing, it's full-time bracing. That's what the BrAIST study showed. Now, what we don't know and we're trying to define today is an exact prescription for each individual patient. Because I think we could say from the BrAIST study that some people did really well with, let's say, a lesser dose of brace. They didn't have to wear it quite as long, and they did well. And some people needed to wear it a long time. And maybe some patient might need it 23 hours a day, and another might be 16. We don't know that yet. But that's what we're aiming for, is a specific prescription for each individual child. So right now, the aggregate is for this high-risk patient, 20 to 40 degrees or 25 to 40 degrees, who's skeletally immature. To me, they need to wear the brace, 14 to 16 hours a day. But I also tell them you can never wear it too much. But the other factor is you're dealing with adolescence. You're dealing with one of the most important times of your life, where you develop as an adult, and the interactions of teenagers is quite complex. So you have to have a life. The child has to be able to participate in sports. They have to be able to participate in dance or do things with their peer group, and they can't be 100% restrained from doing those by a brace. I think that would be an adverse effect on childhood and development. And then also there's a big push on scoliosis specific exercises, so-called Schroth therapy. And I 100% support Schroth therapy. I think if you're going to do exercises, which I do think are important for your trunk, you may as well do scoliosis specific exercises under the guidance of a Schroth therapist. I can't, and I don't think we can honestly say that necessarily affects treatment. There's not high level evidence like most of the things we do, except for bracing. But I support it 100%. Makes sense to me. If you're going to do exercising, which is good, you should learn how to do scoliosis specific exercises. And I would say anecdotally, we have patients who swear by them, grown-up patients who do them religiously and feel it makes all the difference in the world. And so we offer that to all of our immature patients who are undergoing bracing as well, and our mature patients who want to do something about their curve to be an active participant in treatment. So I 100% support that as well.
I completely agree. Now, with adolescents who have reached that parameter of and the curve is still progressing above 40 degrees. What happens at that time? Do you stop bracing, or you still continue bracing to see if you can perhaps impact curve progression? What are your thoughts on that?
If they're still immature,
Yes.
if they're still immature and the curve is over 40 degrees, there's no high level evidence to support continued bracing. But I think the realities are, what do I do? I begin the discussion of surgery, but I also feel that the brace, even if it's not controlling progression, at least keeps the curve somewhat more flexible by use of the brace. So I might have the child sleep in it at night, but they've already failed.
Right.
But I would like to keep the curve as flexible as possible. So I anecdotally have them sleep in it at night, but not during the day. Let them do their normal daily activities, and then rediscuss it in another 6 months, see how it's doing. If it's continuing to get worse, then I'm advising more towards surgery. But if they're not ready to decide, let's visit again in 6 months. It's not an emergency surgery, it's elective.
Absolutely. With respect to bracing, is there a particular style of brace that you prefer over others?
Yeah, that always comes up. But in our BrAIST study, we just let the centers use the brace that they were comfortable using, because there are many models of bracing, and your listeners may look up online. There's 3D bracing, three-dimensional bracing. There's different kinds of brace. And fortunately, after the BrAIST study, there's a lot of interest in bracing. So there are new designs that people are working on. But I can't honestly say to anyone listening today that there is a best brace. I think the most important aspect is that your treating provider and your orthotist, person who's making the brace, have a good working relationship, and that they're involved together and looking at the x-rays, making sure the brace is appropriately fitting, that the pad pressure is in the right spot. So that I think that kind of relationship is the most important. There is not a best brace at the moment. And no matter what anybody says, that hasn't been proven at a high level of evidence.
Mm-hmm.
And so I wish I could say there's a best brace and we'd all would use it, but there isn't at the moment.
Absolutely.
But what's encouraging is that there's a lot of research being done now on bracing, which wasn't done before.
Well, what I found impressive is that when I read the BrAIST study, and it was up to, like you said, it was up to that particular center to use what brace they were comfortable with. Even with that general parameter, the results were still quite remarkable.
And the other thing about that too is that I didn't determine what's a good brace, but we had representative orthotists from the orthotic community who said this is what we consider a good brace fit. They came up with the consensus, and they reviewed the x-rays of the patients in their brace to say this is a good fit, not a good fit. But it was developed by the orthotic community, who, I might add, had the most to lose if the BrAIST study showed that braces don't work. So I think that's another plus of the BrAIST study, is that the orthotic community was totally involved with what's a good brace and what are the criteria that we would look at on the x-rays, and they had the most to lose.
Well, in terms of the future of bracing, there are 3D braces, Rigo Chenot styles. There are printed braces these days. There are dynamic braces that are on the market now as well, that are in studies as well. Where do you see the future of bracing? What would be the perfect brace for you?
Yeah, I think if you talk to any child who wears a brace, it would be one that nobody can see. That would be better hidden. Number two would be flexible in some way so that they could, excuse me, wear it more and still participate in normal activities. I think those would be the two ideal characteristics. There's cosmetic aspects of it, and the ability to have an effective brace that still allows them to do things more,
Excellent.
like their peer group.
I was wondering, we have a few more minutes. I was wondering if I could go back to some of the details of the Iowa study, if you don't mind. What I found interesting is that it seems that the thoracic curves had the higher chance of progression, which is kind of counterintuitive because you think about the ribs, the structures, holding that area a little bit more rigidly. Do you have any idea why thoracic curves seem to progress more in mature spine scoliosis patients?
Yeah, well, number one, I think they're the most common curve type. That's number one. So there's larger numbers of them. Two is the lumbar spine, because of its anatomy, doesn't have the potential to distort or rotate as much. I mean, you can see very severe lumbar curves, but thoracic spine has so much more ability to actually twist and rotate, even though you have a rib cage and a sternum, which you think might resist it. The ability of the rotation of the thoracic spine is so much more, and because of the anatomy of the facet joints, which are more in this plane, whereas the lumbar are in this plane. So I think just anatomically, number one, there's more numbers, and number two, the anatomy of the thoracic spine, even though it might seem a more rigid structure because it's connected all the way around, just has the ability to rotate more. So you see much larger, you can see, horrendously large curves in the thoracic spine.
Okay, that makes sense. Because thanks for the explanation, because that clears up a lot. It's the anatomy, it's the higher probability of, the higher number of thoracic curves in general, and lots of rotation more is possible in that area due to the alignment of the facet joints.
And also, these children who, get these terrible deformities, also the ribs also change shape. So you have this mobile junction between the rib and the spine, and somewhat of some mobility, I guess, at the rib sternum, but particularly rib spine connections are mobile. So the ribs also distort and the chest cavity distorts. So it's not just the spine that's moving. If the ribs were solid, then maybe it wouldn't happen, but they distort as well.
Absolutely. Now, do you foresee, is there any other studies that are any kind of natural history studies that are in the works, or is your study going to be the gold standard?
Well, I think that our study started out as a retrospective because we had to get patients from the past. And the idea would be a prospective study, which in my opinion is not going to ever happen, because the only countries that could do this would be in the developing world, China, India, and Asia, where patients are not treated. But the resources necessary to get a cadre of patients, follow them for a lifetime, would be difficult. Number two, it'd probably be unethical not to treat patients today. By what we do know. So for all of the flaws of our study, which I'll certainly admit there are flaws, I think it's going to be the best we're going to have for some time, or for the foreseeable future, maybe forever, I don't know.
And of course, the BrAIST study was basically, as you said, cut short because of the ethical dilemma of showing such a positive impact from the bracing. Is there any kind of BrAIST 2 type of prospective study in the works at all?
Well, there should be, because the story isn't over just because the patients reach maturity. And we did a 2-year follow-up of our BrAIST patients as well, because once you reach maturity, it doesn't mean the curve still won't get worse. And we still need to learn a lot more about individual patients, because we all have different genetics. Every 35-degree curve in a girl, the same skeletal maturity is not the same. Our genetics are different. And those are factors we don't know enough about yet to put into the equation. But I think we need to follow patients post-bracing, in my opinion, for a lifetime. And particularly if it's over 30 degrees. And that's what I've tried to do my whole life, is see all my patients over their whole life if they're willing to come back. But I do think we need to continue post-bracing studies. We need to have better monitoring of what we call adherence to treatment. So nowadays, we have another study where we put it, like we did in BrAIST, we have a monitors, how much is the child wearing the brace. In the old bracing studies, it was just self-report, and oh yeah, I'm wearing it 18 hours a day, just like you said, but you know, then it would be in the locker at school and they wouldn't wear it. So you didn't really know if they were wearing it or not. So we need better and continuous data on monitoring of using the brace. We also need to know more about how braces work.
Yeah,
They're all
absolutely.
the same. And you know, the brace moves around during the day. Does you know, the pad may be here at 7 in the morning, but it might be here at 8:30 or 9. You know, it's moving around, and what are the forces generated by the pads? And so there's a lot more research that needs to be done on brace treatment for scoliosis. So I do think there's just a fertile area there for research going forward that would really enhance what we know about scoliosis. And then the genetic research needs to continue, because indeed that's a huge factor. You know, also tissue laxity. We're not all the same flexibility. Our curves are different rigidity and things like that. So if I had a longer life, I could think of about 100 projects to continue this line of research. And I'm hopeful that people will be stimulated that are interested in scoliosis to continue answering questions.
Thank you so much for your time, Dr. Weinstein. Really, really appreciate it. Learned a lot, and your natural history research has opened my eyes to a lot of different options. You know, surgery isn't necessarily the only option. It's patient specific. It's a patient's decision, and I think those words are quite wise. Thank you so much for your time.
Thank you for having me today.